Hi, everyone. My name is Casey Pender, and I'm the National Coordinator for Programs here at the American Liver Foundation. And I'd like to be the first to welcome you to our Life with Biliary Atresia and Beyond webinar series. I would like to introduce you to our National Director of Community Impact, Ivory Allison, who will say a few words about our new Pediatric Info Center.
Thank you, Casey, and welcome everyone. We're so excited that in the end of February 28th to be exact, Rare Disease Day, we launched our Pediatric Information Center on our website, liverfoundation.org, and we'll put a link in the chat in a few minutes so you can all have the opportunity to check it out. This particular section of our website is dedicated to pediatric liver diseases, specifically biliary atresia. We have multiple sections, so there's a section for parents to go on, there's a section for teens and young adults, as well as a children's section, which we're really excited and proud about. We even have a coloring book that parents can go on and download the coloring book for their children, and it's also an educational tool, so they can be coloring while also learning about their liver, particularly if they have liver disease. So it's a great opportunity for them to do that. We will be having an animation video launching soon. We do have a animation video specifically for parents, but soon we will have one for children. So we're really excited about that. So please take the opportunity to go on the different sections, take your child and see how beneficial and useful it is. Please let us know if there's anything you think that we're missing that we can add that could be helpful and informative for others. Thank you so much.
Thank you, Ivory. So today's Life with BA and Beyond webinar series is being delivered on Zoom, and it will be recorded. We really appreciate it if you could mute yourself during the program to avoid any disruptions while our speaker presents today. If you have something to share or have a question, please utilize the Zoom chat feature or raise your hand and share your thoughts that way. Again, please note this program is being recorded and will be shared in ALF's private Life with Biliary Atresia and Beyond Facebook group and on our YouTube channel for folks who might not be able to join us live. So if you would like to keep your camera off, please turn it off now. Now I will introduce our featured speaker. Melissa is a family nurse practitioner. She received her Bachelor of Science in Biology from DePaul University. She received her Master's in Nursing from DePaul University and went on to complete her nurse practitioner training at DePaul University, earning a postmaster's certificate. Melissa joined the Lurie Children's Liver Transplant Team in December 2012. She works with children and families from beginning their journey to liver transplant through the post-transplant care into young adulthood. She is a certified clinical transplant nurse. Melissa has an interest in pediatric to adult transition, and she's the lead clinician for the Lurie Children's multidisciplinary solid organ transition clinic. She is also interested in vaccination pre and post-transplant and is involved in research initiatives surrounding increased vaccination rates for pre and post-transplant children. Melissa, thank you for giving us your time today. I'll now hand things over to you.
All right. Thank you for that introduction, Casey. Hi, I'm Melissa. I'm very excited to be here with you guys today. I'm going to share my screen and get my presentation up here. So bear with me. Let's see. I'm trying to get this to go. Sorry. Let me see if I can move this. Yes, there we go. Okay. Can everyone see my screen?
Yes.
Okay, thank you. So our topic today is you're growing up, how to transition from pediatrics to adult care. Yes, I am a nurse practitioner. I do primarily work post liver transplant, but almost half of my patients have biliary atresia, and that's why they needed a transplant. So I'm very familiar, and I'm very, very passionate about this topic. So today I hope to define healthcare transition for everyone, discuss the importance of healthcare transition, describe the different stages of transition and then the how-tos. When I started with this group just over 10 years ago, transition was kind of a new idea in pediatrics. We started to understand that, we work so hard to care for our patients as they grow up and throughout their lifetime, but then there was never a very formal process to get them to the adult providers that they would need to move their care to as they grew older. So that's kind of where this initiative was born out of. And it's been 10 years really in the making for all different pediatric specialties. So just specifically, healthcare transition is the process of moving from a child to an adult model of healthcare with or without transfer to a new clinician. So there are some rare instances where possibly your doctor will follow you your whole life. But when you're talking about pediatric specialty clinics like liver, you're always going to have to move from pediatrics to adults. So why is healthcare transition important? Well, adolescents are a very vulnerable population. Developmentally, they're wanting to form their own identity, which is new for parents as they're kind of getting ready to be independent and start their own life. Sometimes that time of development and life comes with high-risk behaviors. Sometimes there's medication non-compliance. Adolescents can sometimes put healthcare on their lower priority list. Peer pressure becomes a very real situation when you're in your teens, and then moving from dependence on the parents and the caregivers to independence. So there's a lot of reasons that this is a very important topic to talk about. So when I talk about transition, we use that word transition because it's a continuum. And I say that I joke a lot with my patients. When they turn 18, a lot of things change, in the eyes of the United States and the government, they're considered an adult. So, right away, the onus goes on to them for things like consenting for procedures, certain things like the parents can't call for anymore. But we all know that on your 18th birthday, you don't wake up and you're completely independent and can do everything on your own and take over everything for yourself. That's quite unrealistic. And so as healthcare providers and families and patients, what really we've noticed and learned is that starting early is really helpful, and working through different tasks to help ease a child into independence is really a lot more helpful than just kind of dumping everything on them all at once. So this is where this kind of continuum comes in. So really, most kids by age 12 can start to begin at least the introduction of the concept of transition. And that's how I do it in my practice. We really start young and start laying the groundwork so that it's not a big surprise when you turn 18. And I'm just saying 18. Generally, for pediatrics, there's not a hard cutoff for 18. Usually for my patients, mostly they're transitioning over to adult about between 20 and 22. Certainly there are certain cases where maybe a little bit younger, but I'm just using 18 as the kind of example of when you're an adult. But so you've got to start early and then give kids and families just little digestible things. And then they can get really good at these little things and then build on that. So really, yeah, age 12, you could even start younger if you felt like your child was open to that or mature enough for that. Sometimes we do start a little later based on maturity, but and it's good. In my practice, I do try to just lay the groundwork, set expectations, let families know kind of how we're going to move through this. And to be honest, it really does take a village. So it's not just one individual, it's not one parent, it's not one clinician, it's a whole group of people. So it's the parents, the patients, and usually, when you're working with biliary atresia, there's just a whole team, a multidisciplinary team of providers. So, certainly you've got your doctor, maybe your surgeon, nurse practitioner, pharmacists, nutritionists, social workers. So there's just a whole group of people involved to set this child up for success in their adult life. Now, this slide is a very busy slide, and it's mostly just to demonstrate this kind of continuum idea. So I won't spend too much time over explaining it, but we talk about transition in the younger kids, 12 to 14, again, just starting to lay the groundwork. And then as they are a little bit older, 14 to 18, hopefully they're more open to hearing what we have to say, doing a little more things independently, and I'll get into that in a little bit. And then we're tracking their progress. So every time you're coming to clinic, we're asking, okay, what are you doing to provide for yourself, and then really assessing that. And then as they get a little bit older and a little bit more into that age where you're transitioning, really working to make sure that they are getting independent. So just to drill down a little bit more of what to expect for certain ages. So, for the kids that are 12 to 15 years old, again, we're just kind of introducing this topic, how to manage their own chronic condition more independently. So in clinic, we really start to work towards educating patients about their condition and the treatment, with the goal to provide supportive care to maximize the patient's healthcare independence. So, when you're doing this in clinic, we tend to try to kind of quiz the patient or review with them why they even see the liver doctor. Some children, they are diagnosed with biliary atresia so early in life that it's just a part of who they are. And so sometimes it can just become so routine. Yeah, I take my medicine, my mom gives me my medicine, my dad gives me my medicine. I go see the doctor once a year. Well, why do you see the doctor? I don't know, I just go. So, sometimes even just that kind of starting to give them the basic understanding of what their condition is and what it means. And then, anyone who's taking medications, again, that's a very common thing to just, well, I was told to take my medicine, so I take them, but really trying to help them understand the why of why they take the medicine. I think that helps kids when it does come to issues of maybe not taking their medicine or skipping a few doses or, being a little defiant in that area. If you try to tell them what they're taking it for and what it's doing for them, I think sometimes that can be helpful. And then really at age 12, due to state and federal laws, certain categories of medical information may not be viewed by the parent without consent of the patient. So patients that are 12 years and older are required to give parents and legal guardians access to their medical records, including things like MyChart. It's called Assent when they turn 12. And if you're in any sort of kind of research study or research participant, you'll notice that you'll have the child who turns 12 has to assent to continue to be part of that. Sometimes during this time, we may start having the patient meet with us privately. That also is kind of dependent on the patient and what might be going on in their life. They'll always have their parent there, but they may just say, oh, can you step out for a few minutes while we talk to the child one-on-one. Then a little older, you start to think of 16, 17-year-olds. Now, these kids they could have a job, they could be driving. So, in those aspects of their life, they are getting more and more independent, doing things on their own. So similarly, throughout these visits, we're just trying to kind of support their independence. And here's a time where, it's good to kind of model for the kids what it might be like for an adult. So, sometimes I'll have patients come in, especially if they're maybe going through a tougher time and I'm seeing them more frequently. And we have early morning clinics, they might come and they're just like almost sleeping on the exam table. And so what I try to do as best I can is kind of engage the patient. So it's okay that they sit on the exam table, but I also like to get them a little bit used to sitting next to me, in the chairs by the computer, so that I can more direct things at them and they can get used to answering me back and maybe kind of understanding what questions might be asked. And then what's great about it is that you as a parent are sitting next to them. So you're their support person, you're their champion. So, sometimes the kids will really engage and know, and then other times, it might not be as easy for them, or they might not be feeling it, but, and then the parent is there to augment the conversation. But, I find that to be a good age where we start to really just kind of practice what it'll be like when they're on their own. And then again, they're getting more independent here. They may be more exposed to things in life. So, especially when it comes to liver health, things like drugs, alcohol, are important conversations to have. So, we start talking about that, trying to get an open dialogue. We talk about sexual health, we talk about non-adherence. So some of the, a little more difficult conversations, but the information is necessary to keep them safe and healthy. So, and, depending also on the patient and the family, those can be a little sensitive. So sometimes we will just talk to the patient one-on-one, and maybe they wouldn't want their parent to know that information, and that can be kept private. Or I'm usually actually surprised. So most kids are pretty open to their parents knowing about things going on like that. And then starting to think about future planning, graduation from high school is coming up. What kind of plans? You think you'll go to work? You think you'll go to school? Are you going to go away to school? Are you going to move out of the parents' house? So just starting to get that conversation going. And then really we start to advise that the patient really start taking ownership of their medications and some of their health. But usually the first thing is the medications. It can start earlier than 16 and 17. It usually probably does, but really you'll be working with the younger kids to make sure they know their medications, they know how to take them. And then so that when they're 16, 17, when they maybe have that part-time job or they're traveling because of sports, you can feel confident that they are responsible to take their medications. So that's usually a good time, start a little early so that when they're becoming this age and more independent, they know how to take their meds. And then if a patient has a condition that prevents them from making healthcare decisions, families need to start talking about options for supported decision-making like guardianship and power of attorney. And that's when we also kind of start that discussion around this age. So 18, I already mentioned, this is kind of like a golden age where by law you are an adult. And by law, you are the primary medical decision maker. So a lot of things change on the 18th birthday. If you have my chart, which is access to the medical record, literally right on when they're 18, it'll kind of turn off for the parent, and then the patient who's 18 will have to reactivate it. Now they can put the parent on as someone who can access it, but right away it will shut off. And then for the patient, I mean, yes, all that their health information is protected, and legally providers are not allowed to talk to the parents anymore, but we are able, if the patient is willing, they can do something or fill out a release of information. And so basically what it says is, I, as this patient, give my parents permission to get my medical information. Most kids do. I don't think in 10 years I had one kid not do that. So it's usually pretty easy, and the kids are usually up for it. But it is a necessary thing. At this time, I usually recommend starting to think about, if you are cared for with your primary as a pediatrician, moving to an adult doctor. And I only say that 18 is young, but I find that it's a little overwhelming when you have to change multiple providers at once. And in my practice, when I do transition kids to the adult side, they always, that's one of the things that they like, the child to already have established with an adult primary doctor. So, is it a hard stop? No. I mean, you can work with your pediatrician and see when they want you to transition, but sometimes I think that's a little less stressful if you can do one at a time. And then certainly, every chance we get with clinic, we're always, discussing the impact of drugs, alcohol, non-adherence, and sexual health, just so we can make sure that these kids have the good information. And then, at 18, luckily, with the Affordable Care Act and insurance, things are a lot better. Kids can stay on their parents' insurance till they're 26 years old. And then if you're on the part of Medicaid has expanded so that, when you turn 19, you'll move just into like usually a different policy, but you can remain on Medicaid. So it's still good to start thinking about insurance and just trying to understand it, although it's so complex. But, usually around 18, it is a time to think about that. And then really 18 to 22 is when we start to think about actually moving over to the adult side. So as I said, in my practice, I would say it's usually closer to 20 to 22. But a lot of programs might have cutoffs for 22 years old that you have to switch over. So, if we think about it, if you transition over to an adult provider when you're 22 and we start at 12, I mean, that's 10 years of hopefully really good information to help that child be successful when they go over to the adult side. So what are barriers to healthcare transition? There's a lot of barriers, but that's why, it's so important to focus on it. So fear and anxiety about leaving your pediatric clinician. I definitely encounter that in my practice. It's tough. You've been with someone probably for 20 plus years. So it is hard to move to not only a new clinician, but just a new institution too. Parental anxiety about relinquishing control over the patient's healthcare. That's also very difficult. But I do think those fears can be improved or minimized when we start early and do it slowly, and so the child can demonstrate good compliance, good understanding, so then it makes the parents feel better. Just unknown about the adult side, issues with insurance, patient family participation, financial constraints, lack of communication between pediatrics and adult providers, and a lack of motivation from adolescents. These are all real barriers that we have to overcome. So, in my opinion, medication independence is one of the first and most important things for anyone child with a chronic illness that's going to be on medication for the rest of their life. Because in most instances, especially with biliary atresia and transplant, like I said, the children, when they start the meds, it's, when they're infants, really. And so sometimes I think when they're teens and adolescents, they're just, oh, I take this medicine, and, oh, if I miss a couple doses, I don't feel any different, It's not like when you miss your allergy pill and then you're sneezing and coughing and feel terrible, you don't, luckily you don't feel bad, but also you don't get that kind of reinforcement. If I take my pills, I'm going to feel better, until maybe it's, weeks or months down the line, and then, you have a problem. So, really helping the kids to understand why they take the medication, I think, is helpful. And then really nowadays we have so much technology at our fingertips to help us with remembering medication. So I always recommend using phone alarms. Phone alarms are easy to set. They're easy to have kind of reoccurring. And, every teen that I see, they're sitting here with their phone in their hand. So we know they have these phones. So there's no excuses. But phone alarms don't equal you taking your medicine. So I always have to review that too. You set the alarm, and that means you have to get up and get your medicine, or take it out of your bag, not silence the alarm and then forget. And then there's also apps. There's a lot of apps for medications. The one that we recommend, that our pharmacists have recommended a lot, is MediSafe app. It's a virtual pill box. And so you go in there and you can kind of fill out your meds and when you are going to take them, and then it will send you notifications, almost like an alarm, that you're due for your medications. And then there is also a way for the parents to be included in the app, so that they get sent an alert when the child does the medication. So it's kind of a really cool app. We've had a lot of success with it, so check that out. My Meds is another app that sets reminders to take your pills and get your refills. So, and then as far as refills, most pharmacies have apps now. Like I know the Walgreens app I have, and they'll constantly send me the updates, like you're due for a refill. But so you can utilize those. I would say good practice is to, when you're considering starting this, again, I think, your child best, but 12 is probably a good age to start ish, or in and around there. But I wouldn't just relinquish total control over right away. I would double check and do good monitoring. So how do you double check? I've had a lot of families just fill up a pill box, and then parent will come and check the pill box, make sure it's empty. That's a good way. When the parent is doing the refills, you're maybe getting alerts from the app, like, hey, you're due for a refill. And then you look and there's like half a bottle left. that doesn't quite add up. So just kind of being in sync with your refills, knowing that you're getting it every 4 weeks, and the bottle should be near empty every 4 weeks. Families will just like text if mom and dad are at work or the child's at school, did you take your medicine? A double check like that. And then once as a parent, you're feeling more confident that they can do it, then you can start to pull back a little bit on the double checking. Because sometimes that's a double-edged sword too, where the kids get a little frustrated on the constant following up. But if you both make a plan and you can really observe good independence, no missing doses, then I think, they will be successful. Labs are also a way to get the teen involved, because some medications require a timed lab draw if you're had a transplant and you're taking transplant medications. So, being able to involve them in the decisions, I think gives them a little sense of ownership too. So, especially, you do want to be pretty regimented with the times you're taking your medications, but if we know it's the summer and they're, have maybe a job that they're working later and they're taking their medicine later, kind of involving them in like, okay, well, when are you taking your medicine? Let's figure out when you can go for labs in a timely way. And then there are some resources and just kind of like how-tos of transition. So as I said earlier, not to overwhelm people, but you're going to have to change your primary doctor too. So I find that to be the best first step once you're kind of 18 and around that time is switching over to an adult provider for your primary care. If you have multiple specialists or your liver specialist, you can get names and contact information for adult people that they recommend. I would definitely do that. Here in my practice, we actually have our own clinic dedicated to transition. And I know a lot of places are moving to that sort of model. So it's kind of a really nice way to kind of wrap things up and then give that to the adult provider. So in my practice, I've got myself on the pediatric side, and then I have partners on the adult side. And we just communicate and we have a clinic together. When I have patients that are ready to go over to the adult side, I will give them the records. And then there's this kind of little in-between time, usually a few months, where they're still a pediatric patient, but they're waiting for their adult appointment. But once they have that first appointment, then they're considered, the adult doctor's patient. But so that's a good scenario if you can get that, because, it's a little more, I think, streamlined. But it doesn't necessarily have to be like that, but just getting names and numbers of who your specialist recommends is invaluable, because, that's who they feel comfortable with your care going to. When you go to that new provider appointment, it can be pretty intimidating. So, good things to do are make sure that you have your medication list. And if you can't remember, like if you have a lot of medications and things, they change, bring your bottles. I tell people all the time, just bring the bottles, because there's a lot of information on the bottles. It's the names, the dosages, how you're supposed to take it, and then actually has your pharmacy information on there. And that's something you'll also want to bring is what pharmacy do you use? You can't just say Walgreens, or CVS. You have to be a little more specific because they're going to want to prescribe all your meds so you don't miss anything. And then they usually, when you have a specialist, they like to know who your other providers are, especially your primary doctor, so that they can send them updates. So it's usually good to have that primary doctor if you can, and bring their information with you. And then, you know, having the child start to participate in the visits when they're young will help them when they get to the adult world. And so, you know, understanding their meds, knowing their meds and their dosages and why they take them will be key. And that's something, right, you just don't learn overnight. So you got to work on that. Knowing what your diagnoses are, any kind of surgery dates, any dates of surgeries you might have had, things like that, any kind of big things that have happened to you, health related. Those are good things to have, because those are all things that they're going to ask you. And sometimes it is, again, just overwhelming to have it off the top of your head. So, you know, again, I always bring back the phone. You know, there's health apps, or just your notes. You can just kind of type a few things in your notes app so you have it. So, you know, you don't feel that pressure when you're asked. Also, MyChart. I've said that a few times, and I hope people are familiar with MyChart, but it's an app. And it's basically, most hospitals have this app, and it's basically a way for you to access your health records from the hospital and communicate with your team. So you can email through the MyChart app, you can request refills through the MyChart app, you can see all your test results. And it was a little over a year ago, they even expanded what patients can see on their side. So you should be able to actually pull up clinic notes on MyChart. So if you're, you know, logged into your pediatric MyChart, when you go over to the adult side, you can kind of show them all the information, and hopefully your team will have sent them information too. There is a website. It's called God Transition. I put the link here. It's a really great website dedicated to this concept of transitioning your pediatric healthcare to an adult provider. There's videos, there's quizzes, like readiness quizzes. So if you have time and want to look over there, it's a really great resource. Okay, that's what I have. Let's see.
Awesome. Thank you so much, Melissa. That was amazing.
Sure.
We would now love to introduce Dr. Ahmad Anouti, a new member of our BA committee and a postdoctoral research fellow at the Digestive Diseases Department at the University of Texas Southwestern, who was born with biliary atresia and went under a liver transplant at the age of 16. Dr. Anouti, I will now let you share your story.
Hello, Casey. Thank you for having me. I appreciate it very much. So, as Casey told you, I'm currently a postdoc research fellow at UT Southwestern, and I'm going to be telling you my story very briefly. So, I was born in Beirut, Lebanon on August 22, 1996. We don't have much BA there. It's even rarer than the US. So, it took a while to get diagnosed. And honestly, the person who did the Kazai was a Lebanese American surgeon who had come to visit his parents who did the surgery pro bono, who happened to be there just visiting to see family. And he did the Kazai. It was done at 11 weeks. I had a healthy childhood to a certain extent. I did well. I had attacks of croup, glomerulonephritis, several complications, but I managed till the age of 16. By 16, I developed hepatopulmonary syndrome. This on its own took around 4 months to diagnose, because despite me having a known history of liver disease and everything, again, a very rare case in a country that doesn't see BA. So it took around 4 months. By that point, I was continuously on oxygen. My saturation without any oxygen tank was between 70 to 75. So it was bad. I had to eventually travel to get a transplant. I couldn't do it back home. There's no transplant program and my prognosis wasn't great. So we traveled, my dad and I got the transplant done on August 6, 2013. Following transplant, I thought that that would be the end and everything would be fine. I went back home in September, and within a week of being home, I developed acute rejection. I had to take another trip, another 12-hour flight to go back to my medical team to get managed there. On my flight there, it seems I caught a bunch of cocktails of viruses. And coming back home from that, I was diagnosed with CMV EBV positive in November. And by mid-November, I had full-blown PTLD. I dropped around 35 pounds in 2 weeks, 32 to 35 pounds. And I was cachectic and not eating and not doing anything. And this is when I started the treatment. So it was PTLD that developed into non-Hodgkin's, full-blown non-Hodgkin's. I was given my treatment, and it took around 6 weeks on immunotherapy, and I did well. It was a tough time. I was isolated from family, friends, and everything, but I'm doing fine now. And with that history and being a teenager and having to undergo transplant, I decided I want to pursue a career in medicine. So I finished my undergrad studies back home. I did my medical school back home, and now I'm here at UT, mainly focused on research. I do a lot of general liver research, liver transplant research, but my main interests are biliary atresia, and I've been enjoying very much, and I hope to give it back forward people who are like me, who have been through a lot, and who I personally believe through my experience I could relate and hopefully fill the gaps that I've seen in my personal experience. So thank you very much for having me.
Thank you so much. What a harrowing story, honestly. We will now introduce our Q&A session. I have a few questions that were submitted ahead of time, so I'll go through those first, but actually we do have 2 in the chat that we could start with. And if anyone else has any others, you could add them to the chat as well. So we could start with, somebody asked, our 13-year-old had a multivisceral transplant at age 3 in Ohio. Is assent variable by state? We did not have this come up yet.
I thought assent was a federal law when you're 12, but I'm not sure. Assent is more for some of those more sensitive topics that I talked about, and then with any kind of research. So yeah, I'm not sure about that, but usually 12 years old, you have to assent. So, but I wouldn't worry too much about it if you haven't come across it.
And then somebody else asked, an author was on CBS Sunday Morning telling her transplant story. She had a heart transplant at 25 and again at 50. She's now diagnosed with terminal lung cancer, most likely because of immunosuppressants. Any comments about that? I know this isn't exactly, but maybe just a quick comment on that.
Sure. Heart transplants, yeah, I'm not exactly familiar with the story, but they do require higher levels of immune suppression, and their transplants don't last as long as liver transplants in general. But cancer can occur from immune suppression therapy. So, this is part of why after transplant, as Ahmad, even had his own experience, that's why you follow with a transplant specialist. So, we are monitoring the blood counts. We're monitoring for certain things that cause these cancers after transplant, so that we can intervene early. The immune suppression, again, that have contributed to maybe what this woman went through, hopefully is not what we're using with liver transplant. But yeah, we do monitor. I guess that would be my takeaway. We do monitor for these things, and generally the cancer that we see, which is very rare, is treatable. So it might just be a different, also that she was an adult when she was transplanted, and I'm not sure why she was transplanted either. So yeah.
Thank you.
Mm-hmm.
And then another question we have is, Does your pediatric team ever check in on you once you transition?
Yeah, so that's a good question. It's probably team related, I will say, but you know, this I personally am very passionate about this, just because, I want to see my patients do well. So I want to give them all the tools, and that's me personally, but that's really for all pediatrics. It's people are called to pediatrics because they love kids, they love caring for kids, and that doesn't stop when they turn 18. We want to see them succeed. So, there's usually not a lot of communication after you transition, but just speaking around transition itself, I'm not someone that will just like give you a card and tell you to go somewhere else. I think everyone their provider should be following up to make sure that you were able to go there, you were able to be seen. And I do like to follow up and just see how the patient is feeling about it, if they felt good. Was there anything more I can do on their end? So I wouldn't say that there's like a prescribed amount of follow-up, but I do think most places will follow up to make sure that the transition went okay.
Awesome. We should have time for about 2 more questions. So another one is, have you found one tip that has helped children the most when going through a transition?
Yeah. I think for kids, it's important to try to involve them, and it can be difficult. And I find this myself, and because it's just, most times I have such a good relationship with the parent or the guardian that it's an extra step to involve the patient, to give them that time and that grace to answer, to become involved. Usually we have a well-oiled machine with the parent. So just everyone taking a beat to let the child participate, and in my own practice, I will sometimes make a couple phone calls. I'll call the patient, try to get them used to that, and then I'll call the parent, and that's double, but I think just trying to slow down and help them to understand what's going on, and try not to get frustrated and just say, oh, I'll just do it myself. It just takes time and repetitive. They might not get it all in one swoop. You're going to have to try a few times, practice, and things like that.
Awesome. And then we have one from the chat. My daughter had a liver transplant due to being an end-stage liver failure from biliary atresia. Is it common practice to get an MRI after transplant at end stage due to blood toxicity?
Blood toxicity. I'm not exactly sure what blood toxicity. Maybe you're meaning that the level of the tacrolimus was really high, Jamarquez. If that's the case, like right after transplant, they start that new medication, tacrolimus, and if that level is very, very high, we would maybe get an MRI of the brain to image that, just to make sure everything is okay. I'm not sure if that's what you're asking about, but after transplant, sometimes we do have to do imagings like CT scan. We do a lot of ultrasound and MRI just to check on things.
Perfect. And then another question from the chat. Do you incorporate previous transplant patients who have transitioned as part of your team approach and their experience?
That's a good thought. Yeah, we have thought about that. I haven't had any patients come back to talk about it, but here at Lurie Children's Hospital, we have, and I'm sure, many children's hospitals have this, we have something called PeerWise and ParentWise, and that's a support group for our patients, but they link them with someone. If it's a teen, they'll link them with maybe a former teen patient who underwent, a similar circumstances, and similarly the parent. So I have had a lot of patients that have transitioned come back to be peer mentors. But that is actually a good idea, to try to incorporate someone into my clinic. Thank you,
that does
David.
sound awesome. Dr. Ahmad, was there anything helpful for you when you transitioned from pediatric to adult care?
Honestly, I had to learn a lot on my own. The interesting thing was I wasn't really aware of my condition as a kid because I was doing fine. I was getting a lot of infections, but I was doing fine because I had a successful Kazai, and the physicians back home were like, no need to follow up at a certain point. Like by 12, I wasn't really followed up anymore. So when I started developing hepatopulmonary syndrome, it took a while. And this is where I needed to started reading more and learning more. And this is honestly a big part of my work that I think there's, while older kids that get transplants are a minority, they're like 10% of BA patients, they are really misrepresented. So it's good to help kids transition. And the younger kids, it's very important to give them the sense of empowerment to understand their health better, because a lot of mistakes happen if you don't.
Definitely. That just shows how different everybody's transition really is.
Mhm.
And then we could do another question. Are parents still involved in appointments at all once the transition actually happens and they're in the adult care?
Yeah, so I've been doing this for 10 years. And when I first started, our adult counterparts were very rigid and they didn't even want the parents to come. Now we've broken them down, so that's good. And they're not so rigid anymore, but they really do want to talk to the patient, so that's why in my practice, I really do try to talk to the patient and get them used to that so that it's not so shocking when they go over to the adult world. But I'm sure it's adult provider, maybe specific, but they are, they really do want to talk to the child. It's not that the parent can't come in, but, they may direct everything towards the child or the patient. So just being aware that that could happen and having the patient kind of prepared for that is what we strive for.
Yes. And then from that, if you dislike your new adult doctor, do you think you'd be able to talk to your pediatric team to help you find one that might fit a little bit better?
Yeah, I'm always open to someone reaching back out to me. And that happens. And I'm sure most pediatric liver would be very open to hearing. I would never want you to be unhappy with your adult provider. Sometimes it might not be quite so easy. Here in Chicago, we have 4 adult liver transplant centers, but it is a highly specialized. Liver, I think, is a little more available. So you might be able to find someone different. But yeah, I'd always be open to helping somebody find someone new, or actually a lot of adult, if we're talking about transplant programs, those are usually quite large. And so if you didn't jive with someone that you were set up with, you could probably find someone in the practice too that better suited you. I will say that in my own experience, I have one physician that I refer to, and they are, on board and happy to take my patients. So usually, hopefully you'll find someone like that where, they have a good connection with the pediatric hospital or provider, and that they want to take new young adult patients.
Yeah. Awesome. Thank you so much. So thank you, Melissa, and thank you, Dr. Ahmad, for joining us today and providing such an informative presentation. If anyone has additional questions after today's presentation, please continue this conversation in the Facebook group. If you have specific questions regarding this topic, please send them to me and we can work on getting them answered for you. For questions about liver wellness and disease or emotional support for patients at the point of crisis and information on local resources, including physician referrals, please contact our helpline at 1-800-GO-LIVER or 1-800-465-4837. Our staff is ready to assist you Monday through Friday from 9 a.m. to 5 p.m. Eastern Standard Time. We are really excited to announce that our 2023 Liver Life Walk event season has been going great. This year, we will host walks across the country in states including California, Georgia, Massachusetts, New York, and New Jersey, to name a few. For a complete listing of all the states we'll be hosting events at, you go to liverlifewalk.org. We hope to see you on the walk trail. We are also hosting our next BA webinar in July. Dr. Biliary will be presenting Advances in Diagnosis and Management of Biliary Atresia, and you could sign up for that on liverfoundation.org. That is all we have time for today. Thank you all so much for joining us. Thank you again, Melissa and Dr. Ahmad, and we hope you all have a great evening.
Thanks, everyone.
Thank you.